Hi, everyone. Thank you for joining us for the community-acquired pneumonia presentation.
Hi, how's everybody doing? We're really happy we can do this webinar. We're going to talk about community-acquired pneumonia. These are the new community-acquired pneumonia guidelines that came out at the beginning of this month. They're very recent, and so we're really happy to do this. I think it's really good to do kind of guideline talks and talk about what the guidelines recommend. I think guidelines are good to go over because everyone can kind of get on the same page and talk about what's agreed upon. That kind of a lot of people kind of argue over and see what they can agree upon. So trying to get a lot of these people to agree on the what's recommended for everybody is a good starting place, a really good foundation, a really good thing to build on.
And this guideline, so they have like pulmonary doctors, doctors, so it's nice that we're all able to common guidelines.
Yeah, so I like going over guidelines because it's kind of foundational. It's kind of, and then as far as new studies that are coming out and what should be done for kind of each patient individually is it's important to look at new studies, but it's also important to look at what should be done for everybody and kind of the recommendations, kind of the baseline. So we're happy to talk about new studies as well, but I think talks like this where we talk about kind of the overview, big overview, it is a good place to go. So these guidelines, they actually started after the diagnosis of pneumonia was made. So these are patients in the community that are either being seen, well, they're really being seen anywhere. They're either being seen in the outpatient setting in a clinic or in the ER, and really they're presenting from the community. So this is community-acquired pneumonia. They have separate recommendations for hospital-acquired pneumonia and ventilators. But for community-acquired pneumonia, this is once the patient's diagnosed, and they agree that really should have imaging and imaging study, whether it's X-ray or CT, to diagnose the pneumonia. So sometimes we'll get questions about pneumonia, and then we'll look at either the CT or the chest X-ray, and there won't be any kind of consolidation or any kind of really anything imaging. And so I think it's really important to have good imaging studies and show that they actually have a consolidation.
So the first question they asked about in the guidelines is that should we get gram stain culture of the lower respiratory tract for diagnosing pneumonia? And their answer is not always. So, if you're seeing a patient in the outpatient clinic, urgent care, and they're not severe, you could just treat them with antibiotics. You don't need to get them dosed. But then they also say you have severe pneumonia, or you're worried about MRSA or Pseudomonas, or you have had history of MRSA or Pseudomonas, then you should consider getting sputum culture to help with that.
Yeah, and I think this is fine. I think it's when they say not routinely, I think really they're saying if you feel like it's clinically indicated or you're making a clinical decision, you decide you want to get a culture, that's fine. It's never kind of wrong, but they just mean that you don't feel obligated that you have to in every single patient. And I think that's a lot of these kind of recommendations. With these recommendations, they don't want people to say, well, I wasn't going to do this. Well, I wasn't going to do this, but now I will. And I will because I'm feeling forced to because the guidelines say I should be doing it for everybody. All right, so we're going to keep moving forward.
Should blood cultures be okay at the time of diagnosis? And just to remember that last time that the added guideline was from 2007, correct? It was a long time ago.
Yeah.
So this was awaited guideline for us to have now. So in the past, they said, yes, you should get blood culture at the time of diagnosis. But now, again, what they're saying is not routine. So you do, so again, if you have a patient in the community, in the clinic setting, and they're treating them oral antibiotics and they're going home, then I don't think for a patient like that, you need blood culture. But if they're severe enough and you're going to admit them to a hospital where you think it's severe community-acquired pneumonia, or you're worried about MRSA or Pseudomonas, or previously have had MRSA or Pseudomonas, or they were hospitalized and received antibiotics in the last 90 days. In those cases, you could get blood culture.
Yeah, and I think it's that these are, I think, same recommendations, not routinely for everybody. And here, question 3. This is the same kind of question. Should Legionella and pneumococcal urinary antigen testing be performed at the time of diagnosis?
So pneumococcal and Legionella antigen in the past, they said always, but now what they're saying is not routine. So again, it kind of makes sense if you have a patient in the outpatient setting that we're taking care of, that we are using oral antibiotic, you don't need to routinely test. But if a patient has severe pneumonia, community-acquired pneumonia in the hospital that we're admitting, or there's a Legionella outbreak, recent travel, I think it's good to check Legionella urine antigen. Legionella is really hard to grow on sputum, so that's why you get the urine antigen. And about 70% of the time, the Legionella that causes infection is type 1. So it's helpful if you're worried about Legionella to get a urine antigen in severe case.
Yeah, so kind of the older guidelines recommended getting a urine Legionella antigen and on patients that had recent travel, or they're alcoholics, or they're not getting better when you're already treating them for the most common things like strep pneumonia. So if you're treating them and they're not improving, then consider getting a Legionella urinary antigen. So really, best clinical judgment is kind of what these recommendations.
Should a respiratory sample be tested for influenza at the time of diagnosis? So I would say yes during influenza season. So we're in the influenza season right now. So when you have during the influenza season, it's definitely important to check for influenza because you do not want to miss treating for influenza. And also we'll talk a little bit more about if you have influenza, then you have to think about different bacteria when patients come from the. So when influenza is in the community, we check. And the preferred method is to do a PCR test, which is 95% accurate. And the rapid antigen that we do in the ER and clinics are only 65 to 70% accurate.
Yeah, and this is kind of sometimes patients will transfer in, and when they transfer in, they'll say that they had an influenza test and it was negative, and we'll do a PCR and it was positive. And then the concern is that it's going to spread throughout the hospital. So I think if it's possible to do a PCR test, really, I wouldn't trust it, especially and if there's an outbreak, I wouldn't even do the test really. You know that so many patients have it. If it's negative, it's most likely false.
One thing to remember is when the influenza season is here, like September to March, even if an influenza rapid test comes back negative, like Dr. Horn was saying, can still be positive. So treat with clinical judgment if you can do the PCR testing, or also remember giving Tamiflu for these patients as well.
Okay, let me. There are audio issues. Let me try a different speaker here. It seems like we're having some audio issues. I'm not sure if it's a bandwidth issue.
Can you hear us better now?
Okay, we just changed our speakers, so we'll see if that helps. All right, so we'll continue, but please let us know if you're having any issues with hearing us at all. All right, so the next one in adults with community-acquired pneumonia, should a procalcitonin plus clinical judgment versus clinical judgment alone be used to withhold antibiotics? So really, this is as asking, should a procalcitonin be used or not, really? So procalcitonins, I like procalcitonins a lot, but really you should use them in specific cases and understand how how to use them. Otherwise, it can be very confusing. Um,
What I always like to remind everybody, Dr. Horn always likes to say that procalcitonin, we should think of it like propofol. You have to trend them. So one value, even if it's very low, but your clinical suspicion is they have pneumonia, you should still treat, and then you should trend. Usually, sometimes when patients come in, I have had patients that have severe pneumonia. You'll get initial procalcitonin, it's in the normal range, and in 12 hours, it'll shoot up to 10 or 15. So you cannot judge one value. So it's important to trend procalcitonin when we're
right. Procalcitonin was used. You're supposed to check it, and it can take some time before it becomes elevated. Check it, and then check it again. 8 hours, 10 hours. Usually, we'll get a value when they come in. So get a value when they come in, and then the next morning I would check another. So if a patient comes in and they said I was doing fine, I was watching TV, and then all of a sudden I had chills, and I felt extremely cold, and I started shaking and having chills, and then they come to the ER. If they're seen right away, the procal may be low, and then may elevate overnight. So,
Yeah, 12 hours. Good. So I think the takeaway point from here is you should never empiric antibiotics should be initiated in adults when you clinically suspect they have pneumonia with radiographic help. So CT scan or X-ray with clinical suspicion is more important than just using one procalcitonin value.
right, and this is kind of so if they come in and the procal is low, they don't want people saying, "Well, my clinical feeling is that they have a pneumonia, but since the procal is low, I won't give them antibiotics." So that's what you want to avoid. You want to make sure that if you feel like they have a pneumonia, always go with your clinical judgment. And sometimes we'll get a question about sepsis and sepsis protocols, and they'll ask, should we put procalcitonin on our sepsis protocol? And really, my answer to that is, uh, I like procalcitonin, but I don't want to make people get it if they're not used to using it, if they haven't heard about it and not familiar with it, because this is what I fear that they'll get a low procalcitonin and then they'll read about it and say, oh, that means they don't have an infection and they won't give them antibiotics. So is that kind of how you feel as well?
I think of procalcitonin as a holistic. So when you look at a patient when they come in, you look at their white count, they're having fevers, how's they using, and procalcitonin is just another marker to kind of help you guide. So I always say that it's a prognostic marker, but never a diagnostic.
Right, and if it's I completely agree with that, and I wouldn't use because people say, well, why will you order it if you won't base everything off of it, right? So why would we order WBC count if we're not going to base everything off? So it's the same thing where if they come in, I think they have sepsis or I think they have pneumonia, but their WBC isn't elevated. They don't have a leukocytosis. I would still treat them like they had sepsis, right? So I wouldn't base everything off of one thing anyway. I think it's just another value, multiple values that have. So I do think it's very helpful, most helpful if you trend it. And that's the same with a WBC. You wouldn't get it once and then not check it the rest of the hospitalization. You want to see if it's going up, if it's going down, and what's happening. And if it's going down, good prognosis. If it's going up, bad.
Yeah, and there have been a couple of studies. Most of the studies on procalcitonin, they're focusing a lot here, but I think it's kind of important to know is that it's been done on pneumonia patients and on septic. And if you use procalcitonin appropriately and trend it, you can reduce the antibiotic exposure, how long you give antibiotic, and also recent studies have come out. If you know how to use procalcitonin appropriately, there's actually outcomes are better too. So it's just learning to use them and trending them and use them appropriately.
Right, and one more point on this that when you're trying to decide when a patient first comes in if I should give antibiotics or not, that's a really big decision, and that's a really big decision because if they do have an infection, the longer you wait, kind of the worse outcomes they'll have. And so if there's any question, and oftentimes when a patient first comes in, it's kind of a very confusing time. You're trying to figure out what's going on. You might have multiple patients seeing it at one time where it's a lot going on. So really, and this is with sepsis also, if you're not sure, it's better to give the antibiotics, be aggressive up front, and de-escalate later. And that's with sepsis, trying to juggle sepsis with antimicrobial stewardship. It's better to be aggressive up front and de-escalate rather than withhold antibiotics and then say, I don't want to give everyone antibiotics. I'll wait for the patient. Better to give them and de-escalate quickly.
With sepsis, every hour you wait, you increase 10% of mortality. So it's extremely important with antibiotics. Should a clinical prediction rule for prognosis plus clinical judgment, versus clinical judgment alone be used to determine inpatient outcome for adults with? There's a lot going on here.
Yes, I know that sometimes I make these questions too complicated. They
Yes.
should just say, should a clinical prediction rule be used to decide inpatient versus outpatient? But I wanted to copy it and put it up there how they show it. But so clinical prediction rule. So what does this mean? This means really pneumonia severity index versus the curve 5.
So, can we use some of these calculators to kind of figure out where the patient needs to be, inpatient, outpatient? And we have some issues with the pneumonia severity index because it has a lot of variables. We'll show you guys that. Versus curve 65, it was really easy for us to use because there was only 5 different variables to know and plug in and decide, do we treat them as outpatient, inpatient versus ICU?
So when you're comparing severity, curve 65. So with curve 65, it's very quick, right? One of the reasons that people like it so much is that you can look at it very quickly and very quickly decide what to do with the patient. So with all of these different, there's only curve 65. With all these different variables, there's only one that you need labs for, and that's the BUN. So you can look at it and very quickly decide in your busy outpatient clinic where to put the patient. So should they be treated as an outpatient in the hospital, on a medicine floor, or in the ICU? So curve 65 can be very quickly, and really.
And you don't need a lot of lab value either, because only one the BUN, but the rest you could just determine the age, blood pressure, and stuff. So it's much easier to do.
Right. In curve 65, it was first used to look at mortality. So it's used to kind of look at it and see as a prognostic indicator, is there a risk of mortality low, intermediate, or high? And if it's low, there's outpatient, intermediate, you can go to medicine floor, and high mortality ICU floor. And one of the questions is, well, why is this important? Why is it important that they go to the ICU if they need to go? If they go to the medicine floor or the ICU or outpatient? And so they do these studies where they say they track patients, and if they go to a medicine floor, and if they transfer to the ICU within the first 24 to 48 hours, they will look at it and say, oh, they were probably supposed to go to the ICU from the start. And those patients that transfer to the ICU in the first 48 hours have worse outcomes, meaning if they go to a medicine floor when they should have gone to the ICU, there's a higher mortality. They're more likely to die if they don't go to the right spot.
Because they didn't get monitored closely, didn't get the right pulmonary care. So it's really important to get them to the right place.
Right, and using a predictive score like this tries to get everybody to say the same thing. So instead of looking at the patient saying, well, I don't think they look that sick, and then another provider looks at them, oh, I think they look very sick. No, it takes out the subjective part of it. And they want everyone to make the same decision when looking at it. I think that's very helpful when you can try to get everybody to make the same decisions. And with test questions, on internal medicine and infectious boards, they'll have a question where they present the patient where they don't look very sick, and they'll try to say, oh, they feel like they're doing okay, but then the curve 65 score is really high. So they'll kind of hide those things in there, and then you'll have to look and say, no, the present it like the patient's not very sick at all, but you look and it's high, and there's some confusion and things like that. And they should be in the ICU when you look at it, and they try to kind of.
So that was very easy. And this is the pneumonia severity index. And this is more complicated because you have lots of variables to fill in. Comorbidities, demographics, physical exam finding, and laboratory. So not always are you going to have the laboratory findings when you're trying to plug in these values. So, and then, they have the numbers if it's less than 70 versus 70 to 90 and what categories fall under. So it's another tool, and it's, you could Google to get the pneumonia severity index calculator, and you could put these values in, but it's just more cumbersome to be able to do it.
Right, and it's so cumbersome that I wouldn't personally. I wouldn't.
Yeah.
I don't think I would use it.
Yeah.
I think it's better validated, but if you have this many variables,
Yeah.
you might have a better sense of where they should go. But I think if you're in a busy area and seeing a lot of patients, I don't think you have time to put everything on hold. Go through 20 different things, plugging values.
Should a clinical prediction rule for prognosis plus clinical judgment versus clinical judgment alone from inpatient general medical board versus higher level of care, ICU, step down, telemetry, by our community partner?
So the last one was for inpatient versus outpatient, and then this question is for medicine floor versus ICU. And so this one they said, really, they went back to the 2007 severity criteria, and so they said they're trying to be as strict as possible as far as what things were used for. So what they said was the pneumonia severity index and the curve 65 were not designed to help select the level of care. So I guess they're kind of being curious.
Yeah.
Like they're kind of saying, well, if it wasn't specifically designed for that use, then you shouldn't use it like that.
So there's some conflicting information. So in here, they're just saying we recommend direct admission to patients who are hypotensive, requiring pressure, so they use mechanical ventilation. So if they meet the severe pneumonia criteria. So now this is what they define as a severe pneumonia.
Yeah, so they said exactly that. If they need pressors or if they need intubated, they should go to the ICU. But otherwise, you have to count up these things and kind of see how severe.
Yeah. So they got minor criteria and major criteria. So if you meet one major, then it's severe. But if you have minor, you have to at least have 3 of them. So respiratory rate greater than 30, for example, with really low white cell count, for example. That will, if you meet 3 of those minor criteria, then you become. So it's kind of confusing, and I'm not sure how many people are going to look at this to make their judgment. Yeah. So that worries me a little bit.
And oftentimes when there are order sets, there might be an order set for pneumonia, and there might be another order set for sepsis and septic shock. So when you're trying to look at it, if you have different criteria and you're trying to, because a lot of times people with that are very sick, if they are very sick with pneumonia, they will meet sepsis criteria, and then you have lots of different criteria to look at. So so really, this is used for pneumonia, but when it comes to sepsis and septic shock, you want to make sure that you're also looking at that and not just looking at the pneumonia criteria.
So in the outpatient setting, which antibiotics are recommended for empiric treatment for community-acquired pneumonia in adults? So very good question. I'm actually really happy some of the recommendations they have. So, for outpatient setting, if you do not have any risk factor for Pseudomonas or MRSA, MRSA, they recommend you could actually start patients on amoxicillin or doxycycline, which is, narrower and that, because we're using way too much antibiotics in the outpatient setting. So amoxicillin doxy is much better. But then the third option they give you guys is macrolide, so azithromycin. Unfortunately, if you look at the resistant pattern in the US, every state, the azithromycin is over 50% resistant to streptococcus. So I would not ever trust azithromycin as a monotherapy for a patient in the outpatient setting when you're treating, if you want to acquire pneumonia.
Right, and I completely agree. I think that I was actually expecting them to take off macrolides altogether. Yes. I think so. They left it on there if local resistance is low, but even 25%. I mean, that seems.
When I looked at CDC data, every state macrolide resistance for strep pneumonia is over 50%, some up to 50%. So using that as a monotherapy to cover for strep pneumonia will not be ideal, because your table right on the next, it shows outpatient, inpatient in the ICU. It's always strep pneumo is the #1 cause of pneumonia. So we should, so if you have over 50% resistant with azithromycin, that should not be a go-to.
Right. Whatever you give, make sure you cover strep pneumo very well. So, yeah, I mean, I completely agree. And then with comorbidities, it recommends amoxicillin clavulanate or a cephalosporin and a macrolide or doxycycline or monotherapy with respiratory fluoroquinolone. Now, this is kind of interesting because I don't know, I can't really think of patients that don't have comorbidities.
Yes.
You know what I mean? So
Yeah.
I think pretty much every patient we see has a lot of comorbidities.
Yeah. So in an outpatient setting, if let's say you have a 30-year-old patient coming in with pneumonia, I think without any other health issues, you could give amoxicillin or doxycycline. But let's say you have a 50-year-old with type 2 diabetes and
Right. COPD,
COPD.
or any lung issue.
Yeah,
lung
exactly.
issue.
In those cases, I think augmentin or cephalosporin with a macrolide or doxy is better. So you do augmentin or you do like ceftonir and either macrolide, azithromycin or doxycycline for your atypical coverage. On the bottom, they also mentioned monotherapy with respiratory fluoroquinolones, which are moxifloxacin and levofloxacin, not Cipro.
Right, and because they have good gram-positive coverage.
Yeah. They're okay for your lungs for pneumonia, but my thing is that and also for antimicrobial stewardship for our patient safety, fluoroquinolones are more and more having so many side effects, causing gram-negative resistance. Big reason for C. difficile infection in our community, in our hospital. Now we have aortic dissections related to fluoroquinolone. There's a black box warning. Tendinitis. In elderly patients, when we use fluoroquinolone, it's associated with delirium. So there's so many bad things with fluoroquinolone. This should be on the back pocket, if only if they have allergies and things like that.
Right, a beta-lactam should always be preferred at hospital.
Yes. So always beta-lactam and other agents before we jump forward.
All right, moving forward to question 9. In the inpatient setting, which antibiotic regimens are recommended for cure treatment of community-acquired pneumonia without risk factors for MRSA and pneumonia? And so, in patients with community-acquired pneumonia, now previously in the 2007 guidelines, they look at where are they being treated? Are they being treated on the medicine floor or in the ICU? And part of that was because some of the bugs were different. So they get some bacteria make people more sick than others, and the bacteria, the etiology actually turned out to be a little bit different if they're more sick. But here in the new guidelines, they didn't want to restrict it to location. They said there are a lot of different reasons people might be boarding in the ICU, or they might be in one location when really they should be in another. So they didn't want to say it based on location. They wanted to say more base the decision for antibiotics on how severe the patient is. So if the patient is non-severe or severe, and this is based off of the criteria that
we just talked about, hypotension, needing mechanical ventilation, or if you meet those 3 minor criteria. So for non-severe patients, a beta-lactam, a ceftriaxone plus a macrolide. Again, you can use monotherapy with fluoroquinolone again, but think about all the side effects. So I prefer beta-lactam with a macrolide. In severe patients, also they recommend treatment, beta-lactam with macrolide, but they give the additional information.
Right, and so is the patient non-severe or severe? And then what's their likelihood of having MRSA or pseudomonas? And when you give beta-lactam plus a macrolide, really the macrolide and beta-lactam together, kind of think of it as double coverage for strep pneumo. The macrolide isn't so much for atypical as it is to use 2 antibiotics against the most likely thing, which is strep pneumo. So here it says prior respiratory isolation of MRSA. So that if they've had MRSA in the past, add MRSA coverage, get cultures. And so I think this is also where it comes in, where it was saying, should cultures be done on everybody? And they said, not on everybody, but if they've had a history of MRSA or had a history of pneumonia, then you can get, and really here you're getting cultures to de-escalate. So you start them with coverage and you get cultures. And if it comes back and they don't have MRSA, they don't have Pseudomonas, you can de-escalate.
And one thing to remember is that some places you guys have MRSA PCR, you do a swab of the nose, and if it's positive or negative answer, you get it in 1 hour. And some places we do swab the nose and get culture back in 24 hours. So that and lots of studies have been done. If your MRSA in your nose is positive, cover for it. If it's negative, you comfortably stop the MRSA. So lots of VA studies, because in the VA they treat all patients for MRSA, and from that data we know. So it's something to use in your clinical setting. If you have somebody on Vanco and you don't know if you stop or not, to do an MRSA nasal culture or PCR to help guide that.
And here, so it's initial therapy, and this is continued inpatient immune-acquired pneumonia. Severity and risk for resistance is decision what to give. So recent hospitalization with IV antibiotics and locally validated risk factors. So locally validated, that's your antibiogram. So if the antibiogram, you have a lot of MRSA and a lot of Pseudomonas, then consider giving coverage. This says obtain cultures, but withhold MRSA coverage unless culture results are positive. So if the patient's not non-severe, so they're not severe, it says you don't need to cover it, but get cultures and then consider adding it if it turns out to be positive. But if they're severe, you would add it and then de-escalate. And then here, recent hospitalization and risk factors for Pseudomonas. This is the same idea. So you don't need to cover really for MRSA or Pseudomonas if they're not severe. Now, this is all, if you say to yourself, I think I should cover, you'd never have to do, you're never, you would never have to say going strictly off the guidelines. Clinical judgment trumps all of the guidelines. So we never say you're wrong if you wanted to give it, if you want to give it for 24 to 48 hours and de-escalate.
And I think the reason they're saying this is when you have what we used to see is anybody coming from the community that had community-acquired pneumonia, immediately they just got vaccinated dose and results. So without any culture results. So what they're saying is if the patient is not severe, stable in the hospital, let's not jump to MRSA Pseudomonal coverage. For MRSA, get Pseudomonas culture PCR, and for Pseudomonas, obtain culture. And if either of them comes back positive, then you can add the coverage. But if it's a severe case and your clinical judgment is wanted, Vanco or those things have a fraud, and those are okay and get culture. So they're just trying to eliminate always giving Vancos as a practice.
Right. They don't want people to say, the guidelines say I have to do this for everybody.
Yeah.
And then I just wanted to include this again. This is from the 2007 pneumonia guidelines. This is wanted to emphasize that ideally, when you're thinking of what antibiotics to give, you would think, what do I want to cover? And then give antibiotics based on what to cover, instead of thinking of it as pneumonia, you always give this, you always give that. So I just wanted to stress that whatever you give, make sure that you cover strep pneumo very well. And then there are some other things. Staph aureus is only really in the inpatient ICU. It doesn't make one of the top lists for outpatient or inpatient. But if someone's very sick, meaning they got community-acquired pneumonia, they got pneumonia out in the community, and then they go into the ICU and they're very sick, strep pneumo can make people very sick. And that's something that some people sometimes don't really realize, because people can get a little bit sick, or they can get fulminant and die quickly with strep pneumo. And it also has Staph aureus and Legionella. So Legionella shows up on inpatient and the inpatient ICU. So if the patient continues to get sick and you haven't ordered a Legionella, that would be a good idea. Or to start covering until that comes back.
Like I think, and they addressed it in one of the questions for Legionella, if you have a severe pneumonia about that, or recent travel, or if there's. In the inpatient setting, should patients with suspected aspiration pneumonia receive additional anaerobic coverage beyond standard empirical? about aspiration, should you be adding anaerobic coverage? And the answer to that is
So just like the other ones, they said not routinely. And so they said don't routinely add anaerobic coverage for suspected aspiration pneumonia unless you're concerned about an abscess or empyema. So with this, and so these recommendations just came out this month, and already I've had questions where people will call and they'll say, in the past we've always added anaerobic coverage. Should I add it to the patient? And really, what this is saying is that, and I was talked to somebody today about that. They said the patient's getting treated, they're getting better. Should I add anaerobic coverage? Usually add it for aspiration. And my answer was, if the patient's already getting better, you don't have anaerobic coverage, you wouldn't have to add it. That you're feeling, because you don't feel obligated to add it on every patient. And I think this is actually going to cut back on a lot of metronidazole and be able to narrow a lot of.
I feel the same way too. Emphasizes if you have lung abscess or empyema, you have loculated fluid, so anaerobes like to live in there. So in those cases, you should always cover. But in aspirate, patients who have swallow issues and they're aspirating, sometimes it's just chemical pneumonitis. You aspirate, it causes some inflammation, it kind of calms down. You really don't have like a lot of anaerobes getting in there. So I think, like you said, if they're getting already better, you don't need to escalate therapy to add for anaerobic coverage.
Right, and it's kind of, oftentimes when we add anaerobic coverage, we do it because we feel obligated.
Exactly.
Right,
Yeah.
because now, as far as sending, anaerobes die when they're exposed to air, and so really, when we're thinking about adding cultures, if I've also had questions about adding swabs of skin for cellulitis. Now, if it's exposed to air, then you wouldn't add anaerobic coverage. I think our lab doesn't add anaerobic coverage for swabs unless it's a body.
Yeah. And we have a question: thoughts on using strep pneumo, urine antigen, and Legionella urine antigen screening? So I think those are great questions. And I would use them if any of your patients fall under the bucket of severe community-acquired pneumonia. If they have that definition, if they meet the definition, if you're worried about severe pneumonia, then I would definitely get your strep pneumo urine antigen and surprisingly, I would say in the last month I've been rounding. I've had about like 3 Legionella infections.
Oh wow!
Yeah, we don't have an outbreak, but like.
Well,
but,
yeah. Oh, and part of it's in your community if you see a lot of Legionella or not. And part of that is water's treated.
Yes.
I think ours has monochloramine in it, so it treats Legionella. But if people come from other places
or travel,
I'm seeing a plumber. So if you think about a connection with water, or someone that we've had gardeners that they have misters and things like this. So I would, if a patient is severe, I would get it.
Yes.
Or if a patient has risk factors where you're thinking about it, or they're not getting better on their standard. We had another question: lactic acid greater than 4. So really, sepsis criteria would be lactic acid. I think it's 2 or greater. So if it's 2 or greater, then you'd want to recheck it for patients that you're suspecting sepsis. So they didn't have lactic acid on these pneumonia severity, but as far as sepsis, you would want to make sure.
Yeah, and I think one thing to always remember, that's a good question.
Yeah.
Because if you're worried about sepsis, I think then you have to treat broadly because you don't want to fall out with your sepsis.
Right.
So in those cases, you give them broad therapy and then you try to figure out what's going on.
Right. You want to be very aggressive.
Yes.
Okay, question 11. Now, this was just trying to get in line with the hospital-acquired recommendation. So abandoning the use of healthcare-associated pneumonia. So healthcare-associated pneumonia isn't a thing anymore.
Yes.
So they used to think that healthcare-associated criteria helped decide what etiology was, what bacteria, but that wasn't the case. So we don't use the term healthcare-associated.
So if a patient comes in with pneumonia, they were in the nursing home recently, that doesn't automatically put them at high risk for Pseudomonas or MRSA. It's that, have they had in the past Pseudomonas or MRSA? Or should you be testing? That's fine. Are they severe or non-severe community-acquired pneumonia? But but the healthcare associated pneumonia category has completely gone away. I think that's really important.
Okay, in the inpatient setting, should adults with CAP be treated with steroids? So it's asking for every patient that comes in, should they get steroids with pneumonia? The answer is, I wouldn't give steroids unless they meet surviving sepsis campaign recommendations.
So only if you're in septic shock and you're doing stress dose corticosteroids, otherwise we cannot be steroids.
If the test positive for influenza, should the treatment regimen include an antiviral therapy? So if they come in, you diagnose pneumonia, they have infiltrate, they have a consolidation, and their influenza test is positive, should you treat with antiviral?
Yes. So it's been for, I think, about more than 2-3 years now. Anybody that's sick enough to get to the hospital for influenza plus pneumonia, we should be treating them with Tamiflu. And they should also be covered for MRSA. Patients who have influenza and pneumonia, they are one of the big bugs that always affects them is MRSA. So, if you're going to do a community-acquired pneumonia, ceftriaxone, azithromycin, do ceftriaxone and dox. So you're covering for community-acquired pneumonia and also adding the MRSA coverage. But yes, you should be giving influenza treatment with antivirals. And it doesn't really matter anymore about 48 hours versus not 48 hours. Even 5, 6, a week later, if they're sick enough, give them the antiviral.
Right. If they're in the hospital, treat them with oseltamivir. And then in hospital with community-acquired pneumonia, who test positive for influenza, should they also get antibiotics? So the answer is yes. So if they come in, they test positive for influenza, they have a pneumonia on imaging, then you would give them antibiotics as well. And sometimes people will say, well, how do I know it's not influenza alone? And that's a very good point. Sometimes people say, well, if the influenza is positive, then that means I can stop all antibiotics. Well, it turns out that the risk of dying is so high if someone has an influenza plus an overlying bacterial infection that they recommend giving antibiotics if they have consolidation or something on imaging and a pneumonia.
So if you have any clinical suspicion, imaging finding that's concerning for pneumonia, treat with antibiotics, always cover for MRSA until you have cultures back, and give antibiotics.
Right, and so wanted to stress that Staph aureus, in each setting, strep pneumo is the number one, but after influenza or during influenza, they have a super infection with bacteria. Staph aureus moves up. So, well, sorry, did I say Staph aureus? Strep pneumo is the number one, but Staph aureus moves up in the setting of influenza. So with infiltrates, these are the classic infiltrates, patchy alveolar infiltrates with influenza. But even if they have this, you would still treat with an antibiotic.
Yeah, because it's so hard to say if you don't have a bacterial infection on top. So it's really important if you suspect, treat with antibiotics, get sputum culture, and then kind of de-escalate.
And so as far as bacterial pneumonia, classically it's a lobar consolidation. So no matter which one you have, you want to give antibiotics, even if you're suspecting influenza. Strongly consider giving antibiotics. Give antibiotics, yes.
In outpatient and inpatient adults with community-acquired pneumonia who are improving, what is the appropriate duration of antibiotics? So, before we were at 14 days, then we came down to 10 days. So now we know that the less is better, and lots of people who are not in a complicated situation get better at 5 days of community-acquired. The new treatment is around 5 days for community-acquired pneumonia. Unless
they're not getting better. So when I get called, and I'm sure you have the same question for people when they call and say, how long should I treat this patient? They've been on antibiotics for 7 days. My first question is, how is the patient doing? And if they say, oh, the patient's doing very well, they're eating and they're feeling better, everything is really improving, then you can stop. Then it's good. If they're still in the ICU and they're not doing well, then it's going to be different. But if the patient's doing well, they've been on antibiotics for 5 days, then stop.
And if they're not doing well, you need a little bit longer. the 7 course okay, or a little
Yeah.
longer. But for people who are doing well and symptoms are resolved, 5 weeks.
In adults with community-acquired pneumonia who are improving should follow up chest imaging to be obtained. And they said not for everybody. So really really the follow-up imaging is to kind of look and see that once the opacity disappears, once the consolidation is gone, do they have a cancer hiding out in that pneumonia? And so really the high-risk people are people that have been long-term smokers that in the classic presentation, they have a pneumonia, they get treated, and then it comes back. Once they stop the antibiotics, they have a pneumonia again. So post-obstructive pneumonia, really, the risk is that they have a cancer there, and then it's causing obstruction, and then even if they get antibiotics, the obstruction is there, and they get this pneumonia.
So for routinely, you don't need testing to follow up.
Right. If they have a lot of big smoking history and
Things
concerned,
yeah.
then you would definitely get a follow-up X-ray at about 4 weeks or so. And when patients have a pneumonia and they feel like they're improving, sometimes they'll follow up in clinic and they'll say, I feel much better, but I'm continuing to have a cough. And that's okay. The cough can actually keep going on for 3 to 4 weeks.
Yep. And then another time that you should do a follow-up imaging is lung abscess or empyema,
Yes.
loculated fluid in your lung. Drained it, but it's always important to go back and look 4 weeks later to make sure it's not coming back again. But other than that, for routine community-acquired pneumonia,
Right. With any kind of abscesses, lung abscesses, I like to do re-imaging at about 4 weeks or so, 3 or 4 weeks, making sure it's resolving. Sometimes people will be on antibiotics and they'll feel better. And once they stop, it's still there and they still have a problem. So instead of saying, this many weeks for every abscess, abscesses can be big, they can be small. It's better to just
individualized for each patient.
right, repeat imaging and looking at that patient, seeing how bad it is. So that's what we'd recommend. And sometimes patients will come into the clinic a week after they've been admitted to the hospital, and their imaging will look worse. I wouldn't recommend doing extending therapy or restarting. I would just wait. That can take some time to resolve. And then this is a summary of all the recommendations, the 2007 guidelines, 2019 recommendations. This is kind of a summary for you kind of to have, and if you want to refer to this, we'll send out the PowerPoint for everybody.
And then we have another question. Does procalcitonin have a place in discontinuing antibiotics if it's less than 0.25% of the peak? So of the procalcitonin. So how I think about procalcitonin, again, it's a prognostic trend. So if you suspect clinically and imaging-wise, you suspect pneumonia, but let's say you have a patient when they came in and day 1 their procalcitonin was 10, and on day 5 the procalcitonin is 2. There's actually studies show if the procalcitonin has dropped 80% of it. So if it drops 80% from where it started, you could actually stop antibiotics at that. So at day 5, if it's down to less than 80% where it started, you could stop antibiotics. So that's how I kind of use procalcitonin.
Right, and with stewardship, sometimes patients will be on antibiotics a long time, and they'll say, they've been on IV antibiotics in the hospital. We're going to send them home. What should we do? Should we continue IV or go or what? Sometimes we'll check a procalcitonin, and if it has come down like that from the high, you can look at it and say, well, you could stop all antibiotics. That would be okay. And they've done a lot of kind of studies looking at that, and that's really turned out a good way to use procalcitonin is to reduce the duration of antibiotics. And in those patients and in those studies, they found that they reduced the amount of antibiotics, but the patients did the same as the other patients. So the important thing, some studies will show a mortality benefit, some don't. But even in the ones that don't, they would say, well, why would you do it if there's no mortality benefit? And you can look at it and say, look at the number of days of antibiotics reduced by a lot. In each study, they reduced the amount of antibiotics. So if the patients, that's a lot of antibiotics. So yes, this is how we like using procalcitonin. And
there's another question. What does balaxavir have in treatment? So Baloxavir is a new antiviral medication for influenza. It's one-time dose for uncomplicated influenza. So I'm used to using Tamiflu or Salmavir, but I think it has a place in uncomplicated influenza, for especially for, like, where do we get in a lot of trouble? Kids have a hard time taking medicine, twice a day for 5 days, 10 days. So if there's a certain population that you can't use it, I don't know the cost. So I think cost might be prohibitive too. So, but Tamiflu works just as well. So I think who will benefit from one dose versus 5 days, and then what is the cost? Kind of looking at it for each hospital and kind of you guys deciding that.
Oh, sure. And like last year, we'd be happy to do an influenza webinar and talk about influenza treatments that change every year. And so
Yeah.
if you'd like to hear an influenza webinar again, that's a big topic.
Yes.
We'd be happy to do that. And if there are any topics that anyone would like us to cover, please email us and send us topics and things that you'd like us to kind of go over. I think we might do kind of a mix of things coming up also. We like to do kind of the top stewardship questions that we get and kind of the top recommendations.
So I think that might.
Oh yeah, so thank you
Thank
everybody
you,
for joining.
everybody. Have a great day.